in my field, they're always knocking around this idea of treatment-resistant depression, treatment-resistant anxiety, treatment-resistant PTSD, or complex PTSD. I put the failure on the physician who's treating, in that I don't blame the patient. I don't blame the client with treatment resistance. I blame the fact that we can't figure out how to fix this. And I think it's an unfair verbiage that you don't just say to somebody, hey, it's your fault, I can't treat you, go to somebody else now. I don't think that's fair. I try my hardest. I have highly difficult to treat patients in that their condition is very, very hard to get past those first few points. And it's very complex because you have a chemical issue and you have a psychological issue. How much of it is it chemical? How much of it is psychological? You have to manage people's expectation, even with schizophrenia. I might not be able to get this down to 0, but if I can get it down to 30%, I can get you functioning. I can get you back to work. I can get you back to school. I can get you going. If it's going above 30%, it's more difficult to do life. But if you can get it down to between 30 and down, I have a very good chance of getting somebody to function at a better level. We're taught in addiction to use motivational interviewing, which is you talk about things, you present it to them, you give them some information, and you kind of anticipate where they are in terms of their willingness to change. Whether you're in the premeditative state, meditative state, action phase, you kind of have to gauge somebody where they're at. And what's interesting in my outpatient, on a normal everyday thing, when I have somebody that presents and they've been using a lot of alcohol, motivational interviewing works pretty good. When you're in an environment like a residential program, it's time limited. I don't have this whole year to be dealing with you. I have a month to be in my residential usually, maybe 45 days. And so doing motivational interviewing takes time. It takes days. It takes multiple conversations. So we kind of push it and we push the envelope pretty hard and we keep pushing it and we try to get everybody behind it so we can keep them on the same page of, hey, you came in here because you were smoking marijuana and you became very psychotic. I don't know if this is drug-induced psychosis yet, or I don't know whether this is a flashpoint for like schizophrenia. But I need you not to use that marijuana now. Like right now, we're going to be treating. I need this to stop. Otherwise, you're just playing with fire. You're going to end up probably in a hospital again or in another place, because if you don't, you're going to have the same thing that's going to happen to you over and over again. So that's sort of our approach. We've got to be able to get in there and say, hey, we got to stop this right now. We're not California sober, right? We are sober. And until we can figure out what you can do with harm reduction, we need to get this thing cleaned up. And so I can see where you're at. Right now, I can't see exactly where you're at because you're just recovering. Give me 18 months. 18 months is when the brain really heals, and I can see where you're going to be really at. They always say, hey, you treat you treat the addiction, and then you got to deal with what's behind that. You got to deal with what's on the other side of the addiction, because that needs to be dealt with. And then also we have to worry about cross addictions. You'll stop one thing, but then you'll go to do another thing. Your brain starts kicking off in a different way. Hey, it's no problem. I can stop smoking marijuana, but now I can't stop gambling. So you've got to be able to address those on both sides. I think that over time, my view has changed on how you treat people or how you approach the idea of being a psychiatrist. When we started Crownview Residential and Crownview PHP program, we started it with the idea that we are going to meet people where they're at. Well, I can tell you, running around town trying to meet people where they're at is really hard. It is time consuming. And so even then, even the beginning seeds of this program, we were able to we had to readjust the way we saw ourselves. We see ourselves as a very compassionate, straightforward group of people who have a nice culture in dealing with people with mental illness. We are a group of people that are very empathetic, and we will stake our claim to helping people. Get them past, assisting them through all this stuff that's been going on with them. The problem oftentimes doesn't come with that. Depending on who I'm talking to, I think that people see me in different ways. I'm a very straight shooter. I tell people exactly what I'm thinking. I don't hide things. I don't have anything up my sleeve. I try to be as upfront with them as possible because I think it's wasting both of our time if I'm not. And oftentimes I can coast along, especially if someone's got a lot of resistance to wanting to be on a medication. I can coast for a minute and try to build that relationship. But oftentimes it's like, hey, I've got to prescribe you something. I see something I can treat. You have a very treatable condition. I'm going to prescribe it, and then you can refuse it. I can't force you to take anything, but if you keep this path, you're probably not going to get very far. It's probably going to end up back in a hospital, back in a program. And so we've got to get this thing done. Let's try to get this done together. And it's a pilot program. I don't know if this is going to work for you. I don't know if this is not going to be the medicine for you. But if we don't try, then we haven't done anything. And so we keep trying to do things in that approach. Oftentimes people can see me as being funny. People can see me as being hard. I've learned my lessons through working in hospitals and working in different places of, how to get along with people. Sometimes it's not easy, especially when people are pushing back at you. And politically speaking, you really do have to try to get a lot of people on your side. So that's to get things done. Otherwise, you're like the lone marauder out there trying to get something done, and you feel like you're on an island by yourself sometimes. I've learned that early on in my residency. You need to get along, because if you don't, then they're going to make your life a lot harder than it needs to be. And I found myself in positions like that before. So with my treatment in psychiatry, what I do is I can be pretty straight, and I can also be pretty demanding. But at the same time, I can back off and really try to listen and try to figure out what's going on so we can kind of get past some of this stuff.